We actually have, multi-day conferences just on anesthesia and congenital heart disease. So I'm going to try to fit this all into about 20 minutes. I don't have any financial disclosures, of course. I'm glad I get to follow the OB lecture because I can remember the specific patient that I had when I was a first-year resident that sort of piqued my interest in adult congenital heart disease. It was this really tiny girl. I was up on OB, first-year resident, didn't really know anything. And she was a Fontan patient, and she was having premature labor. And just the panic mode that everybody went into sort of on the labor floor, the anesthesia team that was, not familiar with congenital heart disease. The patient ended up doing fine. 2 years later, she got pregnant again. I took care of her, and she ended up passing away. But I remember my first year, my father's a retired anesthesiologist, and I called him and I said, I think I want to be an OB anesthesiologist, after I saw this patient. This heart condition that I was just learning about was so interesting. Everybody was uncomfortable with it. I want to learn so that I'm comfortable with this stuff. And then my dad, he's sort of like an old Filipino guy that doesn't talk much, just was sort of silent. And then he said, I think you want to be a cardiac anesthesiologist, and just with talks with my dad, said, I really want to take care of this patient population because it's fascinating to me. And he said, I don't think anybody's ever done that before. I don't think, you're going to have to figure out how to do that. And we'll I'll show you the training pathways, but adult congenital anesthesia isn't really a thing. People do it, people end up doing it, but as far as training pathways, it's sort of following everybody else because we're traditionally a supportive service and we don't have our own clinics and that kind of stuff. So no disclosures. For anesthesia lectures on congenital heart disease, I always just like to start with evolution or teleology or whatever you like to believe in, how we came to be. So fish hearts, pretty interesting. Single atrium, single ventricle, 2 capillary beds for anybody that fishes. And then evolutionarily, we get to amphibian hearts and you start to see 2 different atria, still a single ventricle, lots of mixing of blood, pulmonary circuit, systemic circuit. As we come farther along, reptiles kind of get interesting. You start to see septation of the ventricle, and whether you believe in any sort of design or this is just by chance, it's still fascinating. You start to see septation, you have 2 aortas, you see 2 atriums, you still have mixing of blood in some cases. And then finally we end up with the human heart, standard 4-chamber human heart. And it's just absolutely fascinating from an anatomic standpoint. So these are actual phone calls have gotten in the past year. I work only in the cardiac center, so we'll get these calls the morning of surgery from ambulatory or the general ORs. And sometimes it's the surgeon, sometimes it's Dr. Lin calling because he got consulted morning of surgery. Says, there's this patient here for blank, they had heart surgery as a kid. Or there's some weird report from some outside cardiology note, their heart's upside down. There's a hole in their heart. Somebody called me over and just stood in front of the computer and showed me this one day. The morning of is not the time to consult anesthesia or congenital cardiology. A lot of these cases end up getting canceled, particularly in the community. I end up doing a lot of dental cases in the cardiac operating rooms, which is a little bit weird. We've done a couple of Eisenmangers, a couple of cyanotic patients. I had a 60-year-old unrepaired TET this week. The dentist one time told me, what's the big deal? The cardiologist wants me to do this in the hospital, and I usually just give these patients a bunch of propofol. And that was an Eisenmanger's patient. So that would have been interesting. So just some of the numbers, we'll go through this pretty quickly, but congenital heart disease, depending on what you look at, it's about 0.8% of newborns. VSDs, ASDs, PDA, pulmonic stenosis, coarctation, tetralogy, these are bread and butter lesions that we see in the children and that we see in adults. Usually repaired, a lot of times they sort of slip through the system. How often? The kids are living to be adults. And we talked about transition of care earlier today, which is where sort of my subspecialty is kind of weird. a lot of kids that had congenital heart disease they're 30, they don't want to be at the children's hospital. But there have to be adult systems and good transition of care to get them to surgical sites with people that are comfortable with congenital heart disease. Surgeons that are comfortable with it, anesthesia teams. But not just that. When I brought this unrepaired TET to the PACU and they put the pulse ox on her, and she was 72%, it was panic mode. So you end up having to recover a lot of your own patients. They're not pediatric trained nurses. There's not pediatric trained people, but at the same time, they're not pediatric patients. They're adult patients who are in a specific stage in their life where they're transitioning care. Lots of patients, and this is sort of where this is coming to from an anesthetic standpoint. Adult congenital patients, even if you're doing ambulatory surgery in the community, they're going to show up. Like there are lots and lots of patients. Just depending on which numbers you look at, about 800,000 adults in the US with congenital heart disease, 1 in 150 young adults, 2 million adults, and the people showing up are getting more and more complex, like they're surviving. 2007, more adults than children were living with congenital heart disease in the United States because they're surviving, because we're getting a lot better when they're children. So who takes care of this patient population? Our cardiology colleagues are adult congenital heart disease specialists. They have board exams, they have defined fellowships, they've all done peds or med peds, cardiology, and then congenital heart disease. Surgery has defined pathways for patients needing cardiac surgery with pediatric congenital surgery fellowships afterwards. Anesthesia, good luck. It ranges. When you show up to surgery and you have congenital heart disease, who are you going to get? The general anesthesiologist is probably going to be uncomfortable taking care of anybody with anything other than simple congenital heart disease. I won't mention that in a second. But the training pathways aren't defined. We have defined cardiothoracic fellowships, defined pediatric fellowships. A lot of times the pediatric anesthesiologists really don't want to take care of adult patients. CT anesthesiologists in general don't want to take care of pediatric patients or OB patients. PDCV patients tend to work at centers where it's very difficult to handle the volume of adults having non-cardiac surgery. And one of my fellows just told me, how am I supposed to study for my boards when I've never even seen these lesions or these patients? So as an educational and we're sort of catching up in the anesthesia world. So there are lots of guidelines, and people have alluded to these. The European guidelines, I like how they state it, management of grown-up congenital heart disease. No, not a single word on anesthetic management. The adult congenital, AHA, congenital heart disease, older adult, which is pretty recent, not a single word on anesthesia. And then the 2008 guidelines, the adult with congenital heart disease, it's 150 pages, and there's 1/2 page on anesthetic care. And you can imagine that 1/2 page is not very specific, but if you don't believe me, some of the stuff in there when it pertains to anesthesia, when people ask me who should be doing these anesthetics, every academic adult cardiac surgery program should have access to a regional congenital heart disease center. Pediatric cardiology program should have transfers for adult, and emergency centers should also have referral patterns. And we saw earlier today how some of these centers are being set up and defined. But one of the interesting things is when you look at, for regional adult congenital heart disease centers, cardiologists, of course, congenital cardiac surgeon, nurse practitioner, and then cardiac anesthesiologists, several. But in cardiac anesthesiology training programs, there's no requirement to do a single congenital case. So it's kind of interesting. But, I was recently at a meeting and somebody at the end of their career who's a sort of a giant in the cardiac world said, I just took care of my first single ventricle. But cardiac anesthesiologists, and I think the training pathways we're going to define a little more in the future here. But we stratify in the anesthesia world, we think about it just like the guidelines say, simple, moderate, and complex, or simple, moderate, and great complexity. Simple, small ASD, patients who've had repaired VSDs that don't have any residual sequela. Any cardiac anesthesiologist would be comfortable with somebody with mild pulmonary stenosis, small ASD, this kind of stuff. And these patients can generally be cared for in the medical community. And that's sort of carried over into the anesthesia world. Even though I get calls, you know, my patient has an ASD, what do I have to do special for this lap chole? And it's stuff as simple as de-airing IV lines. You know, we're sort of cavalier in the adult world where one little bubble here and there nobody really cares about. But it makes a big difference if somebody has a history of TIAs, or we can have a emboli across the septum. So patients with moderate complexity, you know, these are sort of your middle line, and these are all just defined by lesion. They don't really go into functional status, which is something that we always do in our preoperative workup, and I'll talk about that in just a minute. The big one here is tetralogy, Fallot. I got a call this week that my friend was doing anesthesia for an aortic valve back in rural Virginia, and on the echo he didn't see any aortic valve stenosis. And when they opened up the chest, the patient still had a wide open PDA, and they ended up on circ arrest and ligating the PDA and having to do an aortic repair because it sort of fell apart. But that's the kind of thing that shouldn't really happen in the age of referral centers. We shouldn't miss that kind of stuff. And of course the economics and the health insurance have to catch up to that. And then complexity, great complexity, cyanotic patients, shunted patients, patients with conduits, Fontan patients. In the lecture before me, we alluded to a case of a patient who was pregnant with obstructive cardiomyopathy. And we did a patient recently for C-section with bad hokum who in her first pregnancy in the community had arrested during delivery, and then got 4 liters of normal saline and went into pulmonary edema. And we ended up doing that case just under regional with an awake patient with invasive monitoring, arterial line, but also talk about monitoring in a minute. But patients who have congenital heart disease, that's great complexity, cyanotic patients, Fontan, single ventricle, the recommendation is patients should be seen regularly at adult congenital heart disease centers, which I think the theme of this conference is that there are specialists that exist that are comfortable and the outcomes differ. And the patients have a better experience also. But the anesthesia recommendations from those 150 pages, surgical procedures requiring general anesthesia or conscious sedation, so anything that would require anesthesia, who are moderate or complex congenital heart disease, should be at a regional center with an anesthesiologist familiar with adult congenital heart disease. So how do you find an anesthesiologist like this? You can't. The way to find him is through the specialist cardiologist. And typically the specialist cardiologist will have a relationship with 1 or 2 people at a referral institution who are comfortable taking care of these patients. I don't think a patient could find me if they tried, you know, going to a website or this kind of thing. But you know, I'm here at Methodist and Huey can find me. But it's like that as regional, you know, it's regional. You know, somebody referred to at Ochsner that the patient had a incarcerated hernia and had a congenital cardiologist take care of him who was comfortable with the case. So I think that's another real benefit of having regionalized referral adult congenital heart disease centers, is that the relationships between providers. If I have a patient who comes to the OR who doesn't have a cardiologist who tells me that they have a congenital condition, I can call my adult congenital cardiologist to see them. So does it matter, you know, what's going on with these patients? We're gonna see more of them. We already sort of said that. So in the anesthesia literature, it's pretty sparse. In 2013, there was this recent paper, and it was a cohort study, and it was perioperative outcomes of non-cardiac surgery in adults that have congenital heart disease. So anybody with congenital heart disease coming in for surgery. And they matched the patient. It was a pretty good sample size for an anesthesia article, 10,000 or so patients. One of the things that they showed was that surgery in adults who have a congenital heart disease, it's just increasing relative to the population, you know. And that overall, patients who are adults with adult congenital heart disease, we all sort of thought this, they have higher morbidity and they have higher mortality. They have more complications. And this was the first anesthesia paper that really put that down. So this is just a graph from the paper that says the x-axis is, of course, just time, 2002, 2009. And these are all patients having surgery. And you can see that as a percentage of the general population, congenital heart disease adults are increasing in how often they show up for normal surgery. Makes sense. They're increasing as a larger percentage of the population. As you get older, your likelihood of having surgery is more common. Not cardiac surgery, just any surgery. Your cataract surgery, your hip replacement, your knee replacement, So here's the outcomes, and let me see if I can get the mouse up here. So this first column is our congenital heart disease patients. Second one is our non-congenital heart disease patients, and they matched them. They did a 2-to-1 match, basically. And you can see over here, statistically, death wasn't more increased. Length of stay and cost was statistically increased. Acute renal failure, pneumonia, respiratory failure, cardiac arrest, DVT, and then composite score. So sort of across the board, they're more expensive, they stay in the hospital longer, and they're more likely to have a complication. So as far as the anesthesia literature on whether adults having repeat cardiac surgery should be at pediatric hospitals or adult congenital centers, that data hasn't really come to fruition yet. There is some suggestion that pediatric centers doing adults versus your general cardiac operating room where they don't have adult congenital specialists, they tend to do better in pediatric hospitals. But with the advent of the adult congenital specialty, it hasn't really panned out, so that'll be interesting. So there are no formal guidelines, but these are the conclusions of this paper, and I thought the way they stated it was pretty straightforward. It's widely accepted that anesthesiologists and cardiologists with expertise in adult congenital heart disease should manage patients with moderate or severe disease presenting for non-cardiac surgery. And then anesthesiologists should remember that adult congenital heart disease is a systemic disease. And I think the group already alluded to that you're not just thinking about a hole in the heart, that there's psychosocial things, there's anticoagulation, I'll talk about PTSD in a minute. There's anatomical concerns. So improvement in patient outcomes is only achievable through a team approach, and that this is a multidisciplinary game. Surgeon, primary care, cardiology, anesthesiologist, and they specifically say CV anesthesiologist, but good luck getting CV anesthesia to cover all the non-cardiac surgeries. That's fairly unrealistic. So when I have a patient who has congenital heart disease across the spectrum, I'm interested in their history. Sometimes, and everybody who takes care of these patients knows, every once in a while you have a patient who's like the most amazing historian. They have all their paperwork. They're talking to you about the surgeon that took care of them when they traveled around the country and all this. More often than not, they know nothing about their history. They have a heart surgery and that's all they know. We don't know about residual defects. Getting imaging is very difficult because people travel as they get older, they move. So going between institutions can be very difficult. Do they have an adult congenital cardiologist that has anything in the chart? More often than not, people presenting for non-cardiac surgery that I've come in on the day of surgery don't. They just don't have any cardiology follow-up. They're lost to follow-up, and we've talked about that before. Do they have any devices? Do they have pacers? Do they have defibrillators? Are they functionally optimized? So something I always ask the patients is, how do you feel today? Is it any different than your normal day? We talk about functional capacity in the anesthesia world as can you climb 2 flights of stairs? And that's our equivalent of 4 metabolic equivalents. And if they can, then the concept of them surviving a moderate risk surgery is pretty good. But in the adult congenital population, they're going to have a decreased functional status and still tell you that they're doing fine. And then anxiety and PTSD. I had a really good talk at dinner last night where one of our speakers from the Adult Congenital Heart Disease Association was telling me that she can't even go snorkeling or put on a diving mask without having PTSD from her surgeries, you know? And in the adult cardiac world, that would get blown by the wayside, you know, because, you know, you need your IV, you need your A-line. But a lot of these patients, something as simple as seeing an IV catheter can cause, you know, really severe anxiety. So this is one subset of patients in the adult world who are patients who are developmentally normal, where we'll do oral pre-medication sometimes. We'll give them oral anti-anxiety medications. If IVs are triggered, then we may do an inhalation induction, which in the adult world is sort of rare if they're able to communicate okay. Things as simple as sedation when we take out chest tubes. You know, in the adult cardiac world, nobody does that. You just pull out the chest tubes, take a deep breath. You might feel some tugging. And, but these are traumatic things that happen to people when they were children, and they're simple, and we can take care of it, but it requires a systematic approach, a multidisciplinary team. I had a patient who just seeing the tape, like the surgical tape, started to just like break out in sweats and get all nervous just because they were remembering when they were a child. So rhythm disturbances, the bottom is the real question. When do we place defibrillator pads? If you're doing a lap chole on a normal patient, we don't place defibrillator pads. If you're doing a knee replacement, we don't place defibrillator pads. The adult congenital population is predisposed to rhythm disturbances, be it pressure overload, atrial changes, suture lines, atrial enlargement. So I put pads on everybody. Everybody gets defibrillator pads. Everybody that certainly relies on sinus rhythm for their cardiac output gets pads to cardioverter in case we need them. Because the certain things in surgery predispose patients to rhythm defects. Electric artery, volume changes, surgical stress, inhalational anesthetic agents. So if I think about placing pads on somebody, they get pads placed on them. The worst is when you have a Fontana and they go into an SVT and then they don't have a blood pressure, and then you're in the general operating room and somebody's running around trying to find paddles. So you just put them on at the beginning, and what's the worst case scenario? You don't have to use them. We also want to know what was done to the patient. And sometimes this is hard because patients aren't great historians sometimes. Is the patient palliated? You know, and these are just, if you're not that familiar with some of this stuff, if they shunts, if they have Norwoods, or they PA banded, with the concept of establishing or increasing systemic or pulmonary blood flow. Which ventricle is doing what? Is the right ventricle systemic? And then sort of as we saw some of the echo images before, how's the ventricle doing? You know, were they corrected? You know, do they have normal plumbing? And this comes into, when we do invasive monitoring, we want to know where our lines are going. This sounds kind of silly, but I can't tell you how many times people put A-lines in somebody that doesn't have a subclavian artery. Or you walk over there and somebody's trying to put an A-line in somebody where they sacrifice the subclavian. Or somebody's tried to float a swan and something, you know, that it's just, but you want to know what the plumbing is, and once you figure out the plumbing, what I recommend to trainees and to my colleagues that don't take care of these patients a lot is draw a picture of it and tape it on the anesthesia machine. And that picture follows the patient through the PACU. There's no confusion. So pictures, or you know, the picture's worth 1,000 words. A lot of the adults we see are TET patients, you know, getting repaired earlier and earlier. Most people are surviving to be adults. And so when we come in for non-cardiac surgery, we sort of alluded to sudden death, arrhythmia, and then the pulmonic valve. So we're seeing more and more pulmonic valves, both transcatheter, which I'm sure Dr. Lynn's going to allude to, and surgical pulmonic valves, because the old transannular patches. So you always want to know, so example of a TET patient, what surgery did you have? Are you unrepaired? Which my patient last week was unrepaired and cyanotic, setting in the 70s with clubbing for tooth removal. But she was actually turned down 2 months ago for her surgery because the cardiac anesthesiologist did not feel comfortable sedating her for tooth extraction because her room air sats were in the 70s when, you know, they had to be taken out. Was the patient palliated? Were they repaired? Because remember, even a lesion like tetralogy flow is a wide spectrum. What's the current state of the pulmonic valve? Do they have a conduit or do they have a native PA? And then melody valves. This is just a quick melody valve picture because I'm sure somebody's gonna. So, anesthesia for melody valves, we're doing them asleep. And we're putting in transcatheter-based valves to address the insufficiency, but anesthetic management then. And then also earlier, somebody alluded to, we talk about Fontans like that's a thing, but there's a large history of Fontans and Fontan circulation. We talked about lateral tunnels, extracardiac, fenestrated, and Fontan conversion surgery and anesthesia for which I'm not going to really go into. But the original Fontan, and if you just think about anatomy, like I've seen somebody, come in and, put their central line here and there, and, whether we go femoral, but most of the Fontans that we're seeing now are the extracardiac Fontan and not having the large atrial suture lines. But anesthetic management of Fontans, we always talk about spontaneous respiration. When you talk to somebody who hasn't taken care of a lot of Fontans for anesthesia, they talk about not using muscle relaxant because they want the patient to breathe spontaneously because it'll encourage pulmonic blood flow. But if you're seeking spontaneous ventilation in a patient and it's at the expense of hypercarbia, hypoxia, and increased pulmonary vascular resistance, you're pursuing a concept, but you're doing a detriment to the patient. Rhythm disturbances, we like normal sinus rhythm. We want to maintain a low pulmonary vascular resistance to encourage, our pulmonary blood flow. But I very rarely, for general anesthetics on real surgery in the abdomen, force the patient to breathe spontaneously. I'd rather have controlled ventilation with the concept of early extubation when they're stable. What else? Since adult congenital heart disease is a systemic disease, and we already alluded to the hepatic dysfunction. For me, the worst case scenario is somebody with, pulmonary hypertension, liver cirrhosis, who needs an emergency surgery. The anesthesia literature, people argue that if somebody has suprasystemic pulmonary hypertension, they have a 30% chance of death on induction of anesthesia. And we talked about 2/3 systemic pressures. The same sort of 1/3 risk of death is followed over into cirrhotic patients having emergency surgery. So adult congenital heart disease, severe, predisposes people to these really, really high-risk categories of anesthetic management. Sort of going down. Collateralization is something that we don't think about a lot, but you'll see a lot of bleeding because, we have collateralization where you wouldn't expect it, especially in surgeons who are unfamiliar with these patients. Cyanosis, protein-losing enteropathy, hepatic dysfunction, and in the anesthesia world, hepatic dysfunction is really, we're really thinking about synthetic dysfunction or no clotting factors, no albumin, low oncotic pressure, right atrial enlargement. So I think if as primary care providers or people in the community, identify cardiologists who are comfortable with this population, and the cardiologists in their communities identify care teams, and that goes as far as everything in the care team. Anesthesia is a small part of that, but nobody wants to have their knee replacement canceled on the day of surgery. That's a lot of added stress for the family. We just know that even in non-congenital or non-complicated medical communities. But early consultation with anesthesia, finding providers that are comfortable with these patients, because not only are they comfortable taking care of the patients are comfortable with people that are used to, somebody comes and says, I have a Fontan. I say, okay. They say, well, anesthesia usually freaks out right now. So the care team model, I think, is really the future. And I don't ever think that there's going to be an adult congenital cardiac anesthesia subspecialty. There is for pediatric to some degree, and there's an organization for it, but it's really focused on pediatrics. So I think the future is really the care team model and finding people that can interact with the cardiologist who's used to taking care of these patients in whatever community you're in, and that's sort of the future here. And then I guess I'll open up for questions. And we can, anesthesia management for congenital cardiac lesions, you could talk an hour on every single lesion, where to place the lines, this kind of stuff. But if anybody has any general questions, I'm happy to answer them. So.